Today I would like to review with you our dry eye evaluation. You may be experiencing itching, burning, gritty eyes, sandy eyes. Many people have allergies or runny eyes. You may not be able to tolerate your contact lenses. You may have blurred vision. You may find that the glare is painful, and you may have red eyes or crusty eyes. Our goal is to rehabilitate your eyes and get them back to normal function by treating the cause, not just the symptoms. Our goal is to help you, the patient, to enjoy life. Hi, I'm James Tearse. I am an ophthalmologist, which is an eye physician and surgeon. I did my undergraduate studies at Stanford. Then I went to Baylor College of Medicine in Houston, Texas. My residency in ophthalmology was at University of Texas in Dallas. And then I spent 6 months on Project Orbis teaching eye surgery in Central and South America. I have been working on the peninsula and serving patients since 1988. My specialties include dry eye analysis and rehabilitation, advanced cataract surgery using advanced technology replacement lenses, and refractive lens exchange. I'd like to review with you normal tearing. The tears come from the lacrimal gland and flow across the eye like a gentle creek and then go down the drain into the nose. The tears come from 3 different faucets. They come from a mucus faucet that helps the watery tears stick to the eye. They come from a watery faucet, and they come from an oil or lipid faucet.
Dry eye syndrome is a condition caused by changes in the quantity or quality of your tears. The tear film comprises 3 layers. The outer lipid layer includes components like cholesterols, fatty acids, and phospholipids. Some components serve to increase lubricity and prevent evaporation, while other polar lipids conjoin with some of the mucins to create greater cohesivity of the tear film. The middle aqueous layer contains numerous essential nutrients supportive of the ocular surface environment. It is water-based and includes components such as lysozyme, immunoglobulins, sodium, and some soluble mucins. The mucin layer components include silicic acid, hyaluronic acid, and mucins such as MUC 1, 2, 4, 16, and 5AC. Some mucins form a cushioning viscoelastic matrix that both protects the ocular surface and provides the even surface necessary for good vision, whilst other mucins function in a glue-like fashion, securing the tear layer to the microvilli and glycocalyx. The blink mechanism is when the upper lid sweeps down and the lower lid rises to meet it. Lids sweep debris away and push the tear layer like a tidal wave. The tear layer compresses to a fraction of its former thickness, absorbing the energy of the blink and replenishing itself evenly across the corneal surface. Within milliseconds of the lid's passage, the tear layer reforms in both structure and function, the energy of the blink harmlessly dissipated. If tears break up too quickly, the mucins no longer function adequately to sustain tear layer cohesion and surface protection. This may be observed clinically as areas of rapid fluorescein breakup. As the tear film breaks up, the lipid and aqueous layers dry up, causing the mucin layer to diffuse away, leaving the ocular surface bare and exposed. This enables an inflammatory cascade, and sometimes irreversible damage occurs. The patient becomes increasingly symptomatic and often experiences visual disturbance.
Now that we've reviewed the 3 layers of the tear film, let's talk about where the tears go. They go down two small drains that are located next to your nose, and every time you blink, it activates the suction pump that sucks these tears down into your nose. Now, many people feel like they have too many tears and that their eyes are too watery. And this comes because the eyes get too dry and develop pain. When you have pain, the lacrimal gland secretes at 100 times the normal outflow and therefore overloads the system. This is what I call the pains flash flood and then causes watery dry eyes. I find that there are 6 types of dry eyes: low water tear secretion, low oil tears, low mucus tears, too much outflow, infected eyelashes, or poor eyelid function. First, let's talk about some treatments. Here's a simple one for you. You can fix your surroundings by moving your computer monitor down. Therefore, your eyes are not as wide open, and this decreases your eye exposure. You can also block the wind by changing air vents in your car or in the office away from your face. Also, you can use a humidifier to maintain the humidity in your surroundings. If there's too much outflow, I use dissolvable plugs to close up one of the drains. These do not irritate usually, and they last anywhere from 2 to 6 months. Additionally, I clean the eyelashes. This is to remove the crusting that is caused by an infection of Staphylococcus or the parasite Demodex. I have found that spraying Avenova directly onto the eyelashes works very well. Avenova is saline with hypochlorous in it. This is the chemical that white blood cells use to kill bacteria and fungi. This kills all the bacteria and probably all the fungi. It inactivates the toxins that these bacteria put out. Additionally, it degrades the enzymes, including lipase, which can cause eye irritation. Fortunately, it prevents biofilms from forming that will then disrupt your tear film. Once you spray it on your eyes, you spray it on your eyes, it will work within 30 seconds and then just becomes saline. When we do diagnosis, I find that we often have people with very dry eyes, and we use lissamine green to find the staining. Also for diagnosis, we're going to ask you to get some blood tests. These include the rheumatoid arthritis factor and ANA, which is anti-nuclear antibodies. This is looking for autoimmune disorders, including Sjogren's syndrome, antibody A and B. Other things that can cause dry eyes include anemia and infections, thyroid disorders, low vitamin D, which I find very common, and in the world, vitamin A. However, on the peninsula, I only find this in patients who have had bowel surgery or severe bowel problems. To increase the watery tears, sometimes I will use either vitamins such as Theralife I vitamin, which increases the intracellular metabolism, and this helps with the secretion of the meibomian glands. Also, I use eye drops called Restasis, and this gives better water and mucus tears. These are used twice a day, and after you put the drop in, close both eyes for 3 minutes so the medicine soaks into your eye. You may use this vial until the vial is empty, such as use it in the morning and in the evening and possibly the next day. The medicine takes 3 months to fully work as it keeps inflammatory cells out, and the present inflammatory cells may take 3 months to die. If you find that it burns, put the restasis in the refrigerator. Now let's talk about oil tears or lipid tear deficiency.
The meibomian glands produce the lipid layer of the tear film in the eye. The lipid layer protects the eye's natural moisture, or aqueous, and allows the eyelid to glide safely over the eye. Cells on the inner wall of the meibomian gland acini produce oil. In a normal eye, when you blink, the lids touch and pressure is applied to meibomian glands, causing them to express small amounts of this oil. The upper lid then pulls the oil upward over the eye as the lid opens. When the gland becomes blocked, there is not enough oil to coat the tear film, and the aqueous evaporates rapidly. Without adequate lubrication between them, the eyelids and cornea can abrade each other, causing inflammation and cell damage to the lid wiper and cornea. Simply removing meibomian gland blockage isn't enough. The acini may not start producing oil again until the accumulation of dead cells within them are flushed. Excessive evaporation of the tear film due to a poor lipid layer from MGD can lead to increasing discomfort, poor vision, inflamed lid margin, and damage to the ocular surface. When MGD is not treated, blockage of the glands results in downregulation of oil production, eventually causing the glands to atrophy, lose function, and drop out. Completely atrophied meibomian glands lead to chronic discomfort and potentially sight-threatening damage to the ocular surface. Doctors now have the ability to assess meibomian gland dysfunction with a meibomian gland evaluator, or MGE. The MGE exerts pressure consistent with a deliberate blink, allowing evaluation of gland secretions in 3 regions of the eyelid. Using the MGE, secretions for 5 glands in each region are scored on a scale of 0 to 3.
Additionally, I measure the oil lipid layer using the instrument called the LipiView 2. This instrument also gives us photographs of the eyelid glands. As you can see, the one on the left has all of the glands present. The picture in the middle is missing a fair number of the glands, and the picture on the right has very few of these white glands and has lost many of the glands. To treat the oil deficiency, I typically start with antioxidants, and I also recommend getting the vitamin D level up. I shoot for 75th percentile of the normal range. Symptomatically, I treat using artificial tears and ointments at night until we can get your natural production of oils working. Once the oils are flowing, then we can maintain this with restasis drops. To start the secretion, I like to turn them on with an oral medication. Azithromycin pills by mouth go directly into the glands and turn on the oil production. You can help by applying heat to the oil glands. You use the heat for 3 to 5 minutes and afterwards directly compress on the eyelid along the eyeliner line for 3 seconds. This causes the oils to be secreted. Additionally, to help this, I do a treatment. One option is called oil gland probing or meibomian gland probing. Here, I take a small probe and directly go into the glands and break up the oils that are clogging it and try and open up a new pathway. This allows your body to now secrete oils. The other option that we have available is a newer treatment called LipiFlow.
The LipiFlow system uses heat and a 12-minute pressure profile to remove blockages in the meibomian glands. By heating the glands from the inside, blockages are liquefied. Gentle pressure is applied from outside the lid, from the base of the gland to the gland opening, removing blockage and flushing dead cells from the gland. The LipiFlow activator insulates on its inner surface and vaults the cornea to protect it from heat. Therapeutic heat of 42.5 degrees is accurately controlled and directed outward, away from the cornea to the lids. The device never lets the cornea exceed a safe 39.5 degrees, unlike chemical heat packs that have been shown to overheat. Also, unlike manual lid massage, LipiFlow safely applies pressure to the lids, not to the cornea or the globe.
This has been an introduction to our dry eye evaluation and therapies, and we look forward to using the science of medicine and the art of healing to improve your vision.
The tear film in the eye. The lipid layer protects the eye's natural moisture, or aqueous, and allows the eyelid to glide safely over the eye. Cells on the inner wall of the meibomian eye